Yeah, welcome friends to day 2 of Upgradio 4.0. I think yesterday I had all good sessions. It went on till 9 o'clock and all of you participated very actively. And today we wanted to particularly have Dr. Dharam with us. I think he's a very good friend and he's very highly accomplished there. Because of a relation, he agrees to join in spite of his all his busy schedule. And as already told to you in our introduction yesterday, he is the first author for this recent antiplatelet and antithrombotic guidelines which has come. So we are particular that we should have him. So we are fortunate to have his time and request all of you to settle, and Dr. Deepak will briefly introduce Dr. Dharam, and then we'll request him to take over and start his lecture. Dr. Deepak, okay, over to you for introduction. And we are happy that V.S. Ramchandra is chairing the session along with me, and Hall Full is fully eager to listen to you, Dr. Dharam. Deepak, introduction of sir, and then following to speech lecture. Over to you.
Very warm welcome to all on this day 2 session. Here today, we are going to cover that guidelines and structural interventions. So for that purpose, especially from US, Dr. Dharam Kumbhani, he has joined already. So without taking much time, I would like to introduce Dr. Dharam Kumbhani. Dr. Dharam Kumbhani, he is a section chief and director of interventional cardiology, UT, Southwestern Medical Center. Director of Cardiac Catheterization Laboratory at Clementus University Hospital, Professor of Medicine in the Department of Internal Medicine, UT Southwestern Medical Center, specialized in interventional cardiology, structural heart disease and valvular heart disease intervention, complete a master's degree in clinical epidemiology at Howard University, trained in internal medicine at Hospital of University of Pennsylvania, and cardiovascular medicine at Cleveland Clinic. Completed advanced fellowships in interventional cardiology and structural endovascular intervention at Brigham and Women's Hospital and Howard Medical School. Expert in transradial coronary intervention, percutaneous valve therapies, and structural heart disease procedures. He is author of many, means more than 200 plus publications. Then he has a lot of publications like in renowned journal like NEJM, JAMA, JAG, and Circulation. Associated editor of Circulation and contributor to major ACC/HA cardiovascular guidelines, which are recently published. Elected member of the American College of Epidemiology, Sigma XI Research Society, and the Royal College Physicians. So I would like to hand over the session to Dr. Dharam Kumbhani. Yes, sir, over to you. We can switch.
Thank you so much. Really appreciate you the invitation and the welcome. Can you see my slides? Okay.
Yes, sir. Slides are visible.
Okay, perfect. So yeah, thanks again for this invitation, and I'm really honored to speak to you about antiplatelet therapy for coronary artery disease. And so I don't have any industry disclosures. I also work for as an expert for the US FDA. And as Dr. Srinivas Kumar mentioned, I had the honor of chairing the 2026 ACC scientific statement on antiplatelet therapy in the management of ASCVD. So I'm going to share some of the concepts that we've discussed in this document, and hopefully you'll find this informative and a good update of the current state. So here's a brief outline. I'll be talking about antiplatelet therapy, sorry, for primary prevention. I'll be talking about antiplatelet therapy for PCI in acute coronary syndromes. And we'll focus on a few specific aspects, including the duration of DAP and specifically shorter durations. We're going to look at some de-escalation strategies and discuss those. And then we'll also talk a little bit about long-term therapy in this patient population. And then I want to bring up a few discussion points about patients who also need oral anticoagulation in the long run. So I'll try to, maybe just very briefly talk about, we know the platelet is really central to a lot of the pathophysiology of acute coronary syndromes and coronary artery disease. And there are three components to the platelet as far as the vascular biology is concerned. So there's platelet adhesion, platelet activation, aggregation, and that's what eventually results in a platelet plug. And the various agents that we have, including aspirin, P2Y12 inhibitors, glycoprotein 2B3 inhibitors, etc., they all act on different aspects of that. And the other thing to know is it's helpful to understand the basics of the pharmacokinetics and pharmacodynamics of these agents and understanding which of them are reversible versus irreversible. So this is, again, just a very brief outline of what the vascular biology of this entails. Now, we've all been using prasugrel and ticagrelor for nearly 2 decades now, but I just want to remind people that the initial pharmacodynamic data for these 2 drugs. So Principal Timmy 44 studied that for prasugrel, and you can see that the onset of action for prasugrel is very quick, much sooner than a loading dose of 600 of clopidogrel, and the level of platelet inhibition is also significantly higher than achieved with a 600 milligram loading dose of clopidogrel. On the right-hand side, you'll see that for maintenance dosing, prasugrel 10 milligrams achieves higher platelet inhibition compared with even double dose of clopidogrel, 150 milligrams a day. Similarly, this is the onset offset study for ticagrelor, and same thing for ticagrelor. You'll see in green is for clopidogrel compared with orange for ticagrelor, and you'll see the onset of action for ticagrelor with the loading dose is significantly faster. You achieve north of 70-80% inhibition within the first hour, and then you have a high dose, higher platelet inhibition with maintenance dosing. Importantly, the offset of ticagrelor is also very similar. It is a reversible blocker or inhibitor of the P2Y12 receptor, but the offset is very similar to clopidogrel, which is irreversible. So let me start, or maybe talk through some of these concepts by means of a case. So this is a first case. This is a 57-year-old male. He has a history of diabetes and hypertension, and he comes to see you for a regular visit. He's working full time. He's exercising a couple of times a week. He's a former smoker. In office, his exam is well controlled. His A1C is 6.8. His BMI is 28. And his cholesterol is 159 and his HDL is 33. And he takes an ARB, he takes a statin, and he takes metformin. And his question for you is, should I also be on low-dose aspirin for primary prevention? And I think this is a very common discussion point that comes up in clinic. So what is your advice to this patient? What do you recommend in this setting? So let's look through the data. So this is one of the largest meta-analyses on the use of aspirin for primary prevention. So this included 13 studies, nearly 160,000 plus patients. And what we are seeing over here is that aspirin successfully reduces the composite cardiovascular endpoint by about 11%. This includes about a 15% reduction in MI, a 19% reduction in stroke. So there is a CV benefit with the use of aspirin, low-dose aspirin for primary prevention. However, you have to balance this with the risk of bleeding. So there's a 43% increase in major bleeding, particularly in the risk of GI bleeding, but also in intracranial bleeding. And when you look at the absolute risk difference, whether you look at benefit versus risk, it's almost a wash. And so you reduce as many MIs as the number of bleeds that you cause in that setting. So based on this, the 2019 primary prevention guidelines list a 2B indication. So low-dose aspirin can be considered for primary prevention of ASCVD among select patients, 40 to 70 who are at higher ASCVD risk, but do not have the higher bleeding risk. I will point out that it's a class 3 in patients who are older than 70 to be taking aspirin for primary prevention, and also a class 3 in patients who have a higher risk of bleeding. So I think really understanding what that patient's bleeding risk is exceedingly important. Now, how do you calculate the ASCVD risk? So, previously we used to use the pooled equation. Now I think the prevent calculator is much more accurate, also much more multi-ethnic. So this is the prevent ASCVD calculator. And, this is on you can just Google this, and this is on the AHA website. And it goes through all these different parameters that, most of which I actually shared with you as far as, how do you understand what his risk is. And when I entered all the information that, I gave you in the vignette there, his ASCVD risk comes out to be about 6.6%. So his risk of having death, stroke, or MI at 10 years is 6.6%. So if you look at the categories, this puts him in the intermediate risk. And so 5 to 10%, less than 10 is in the intermediate risk. Now, there's no clear demarcation that if you're at a certain number or a certain level, that you should be on aspirin, but it does sort of put things, in perspective. Now, there are certain risk enhancers, so, let's say this patient was someone that you had seen in your office, he would be sort of what in Western literature is called South Asian, but, just Indian ancestry, we know has a higher risk. The other sort of one that has gained a lot of interest recently is lipoprotein A. Now, just having high lipoprotein A levels does increase your CV risk, but it is unclear if that itself can be used as a risk enhancer or risk modifier to justify the use of aspirin for primary prevention. And so the ASPRI study, this was ASPRI, it was a big study on primary prevention of aspirin. And when they looked at patients who had a particular mutation, this RS3789220C, this particular mutation in the lipoprotein A, those patients seemed to really benefit. There was a improvement in 8.1 events per 1,000 person years in patients who carried this particular variant. So this is very hard to genotype. I will also say that the prevalence is higher, about 3.5% in European ancestry, and less than 0.3% in patients of South Asian ancestry. So perhaps in patients we're seeing in India may not be as relevant, but the levels, again, I want to clarify that high LPA levels by themselves are not an indication for aspirin use. Now, the other thing you might use is a CAC score. And so these are data from MESA. And, you can categorize it as, 0 to 100, 100 to 400 or higher. And when you looked at the sort of breakup, in green over here is the number needed to treat. And this red line is the number needed to harm. So when you got to sort of this CAC score above 100, that's when, there was a benefit or the number needed to treat was significantly lower than the number needed to harm, and certainly for greater than 400. So coming back to our patient, the vignette that we discussed, low dose aspirin in this setting could be considered if the CAC score is 100 or higher. Patient has to be low bleeding risk, we discussed that. And then patient also understands sort of the trade-offs that he is at a higher risk of bleeding, but the trade-off is that he would have a lower risk of stroke or MI. So that's sort of how this seemingly, simple issue actually, can require a lot of thought and is very interesting. So let's move on to sort of ACS. So this is a 57-year-old female. She has diabetes and hypertension. She comes to the hospital with an acute coronary syndrome. And this is her anatomy. And you can see she has a single lesion in the LAD, a bifurcation lesion. And she undergoes DES PCI, IVUS guided with a 3O Zion stent, and really nice results. So what is your recommendation regarding DAPT in this patient population? So the 2025 ACC/AHA ACS guidelines, this is directly from there. And so the default strategy for this patient population is to be on DAPT for at least 12 months. So typically a year, and then you would prefer to use one of the more potent agents, which is either ticagrelor or prasugrel. And then there's a number of other sort of possibilities, and I'm just going to go over some of them so, hopefully the nuances make a little bit more sense. So let's talk about DAPT followed by P2Y12 inhibitor monotherapy. So this is, where you start with DAPT and then after a certain period of time, and typically it's 1 to 3 months, you stop the aspirin and then you continue with the P2Y12 inhibitor monotherapy. So this is not a complete list. There are a lot of studies. These are just some of the bigger ones, global leaders, Twilight, Stop DAPT2, Target First. These have all been done looking at exactly this strategy. Now, I will point out none of these trials were individually powered for ischemic endpoints, but they all saw that there was no difference in ischemic endpoints, but the bleeding risk, as one might imagine, you're using one agent rather than two, was significantly lower. Now, this was meta-analyzed, and so when you look at, again, sort of a combination of all of these trials and some others, what we see is that there is no difference. The ischemic endpoint is no different. Death and MI stroke is the same, but you do see a significant reduction of a 51% reduction in bleeding, in significant bleeding, which is bar 3 to 5 bleeding. Now, one thing you really need to sort of take home from this is that the data for truncation or de-escalation in duration of dual antiplatelet therapy are primarily with ticagrelor and to some extent with prasugrel. And I'll sort of come back to this issue. So the data for de-escalation based on duration of DAP with clopidogrel, when that is the sort of P2Y12 inhibitor that is being used, are less clear. So I mentioned stop DAP2, but specifically in an ACS population, this is the stop DAP2 ACS trial, which had about 4,200 patients who were randomized to either 1 to 2 months of DAP and then clopidogrel monotherapy, or DAP with aspirin and clopidogrel continued for 12 months. And their primary endpoint was actually a composite of ischemic plus bleeding. And the truncated duration is up here in blue, and the yellow represents the sort of conventional 12-month DAP. And you can see numerically higher, but actually did not meet criteria for non-inferiority. So this was a non-inferior trial, which basically means that, you know, the trial's uninformative, and it cannot tell you that clopidogrel monotherapy would actually be the same as using DAP for 12 months. Now, what was concerning is if you actually looked over here, this is the MACE endpoint, which was higher, about 50% higher risk with the shorter duration of DAP and then clopidogrel monotherapy. Bleeding was no different, although, it was significantly lower, which is expected. But there was also a penalty, about 2.5-fold increase in the risk of stent thrombosis with the shorter duration of DAP. So this is telling us that, you know, when you want to shorten the duration of DAP and de-escalation based on that, then using ticagrelor or maybe prasugrel is okay, but using clopidogrel may not work for everyone. And similarly, de-escalating to aspirin may also not be appropriate. This is data from SmartDate, which was a study from Korea as well, 2,700 patients. 38% of those were STEMI, so more than 1/3 were STEMI patients. And the DAP was with clopidogrel, but at 6 months, the DAP was stopped, and then they were continued just on aspirin monotherapy. So this is the MACE endpoint, which was similar. On top over here is all-cause mortality, which was also similar, but there was an increase in MI, about 2.5-fold increase in the risk of myocardial infarction with the shorter duration of DAP and then aspirin monotherapy. And as expected, bleeding was actually numerically lower, but not actually lower. And when they did a 6-month landmark analysis, they found that, again, the MACE endpoint was higher, about 70% higher, and about a 5-fold increase beyond 6 months in the risk of MI. So aspirin monotherapy after 6 months in an ACS population may also not be appropriate for every patient. So I mentioned de-escalation a few times. De-escalation, the concept is you're going from something stronger to something, you know, less aggressive. Now, there is de-escalation in duration, which we talked about, but there's also de-escalation in terms of potency. And that can take 2 forms. So you can have guided de-escalation. And so basically, this is where the genotypic assessment becomes important. And so the most important one for clopidogrel metabolism is the CYP2C19 genotype. And so, those who have a loss of function carrier, or they have 2 of those alleles, they are at higher risk of having the lower levels of the active metabolite of clopidogrel, and therefore a higher risk of adverse cardiovascular events. So the way to think about it, this is from a consensus statement that Dominic Angelillo and others had written. If you have high bleeding risk, you certainly should consider using that, or you could consider using that. And if you have no loss of function allele, then you could de-escalate from, let's say, ticagrelor or prasugrel to clopidogrel. But if you do have either 1 or 2 loss of function alleles, then you would stay on those. And then similarly, if you have low ischemic risk, that is something you would consider. And you could consider something very similar for stable disease. Now, I was intrigued by this because, this is very, very much based on the ancestry. And so when you look at sort of the loss of function as far as the CYP2C19, so the wild type or normal is 1-1. And, in European cohorts, that's about 40%. But in South Asian, so patients in India, it would be about 26%. So it is less likely to have a normal genotype, if you will, the sort of wild type. And intermediate is you have at least 1 loss of function allele, which is, by itself, you are slower to metabolize clopidogrel, but you're still able to do it and convert to this active metabolite. But nearly 1/3 of patients in this was a very large genetic study of nearly 2.2 million patients who had submitted data to 23andMe. And nearly 1/3 of patients, South Asians, would qualify as having intermediate, and then around 10 to 11% actually are poor metabolizers. So they have either 2-2, 3-3, or 2-3, and all of those are bad. And again, most of that is going to be 2-2. And I'll point out that I only show like 4 of them over here, but of all the ancestries that they analyzed, the highest risk of having poor metabolizers was in East Asian populations, so patients from China, Korea, Japan, etc. And the second highest was actually in South Asian, so people, patients from India. So this is definitely something to think about. I don't know, sorry, I wish I did, if the genotypic assessment is available, but I think this is certainly something to think about. Now, you can also do unguided de-escalation. So that was guided. Again, the evidence for that, I kind of glossed over that a little bit. There was a study, Popular Genetics, that showed that in European populations, if you use the CYP2C19 genotype assessment to then de-escalate, it actually, you actually had safe outcomes. But you can also do an unguided de-escalation. So this was the Talos AMI study. This was also done from South Korea, where they basically took patients who had been on aspirin plus ticagrelor for 1 month, and then at 1 month they were randomized to either continuing aspirin plus ticagrelor down here, or then they were de-escalated from ticagrelor to clopidogrel. And the primary endpoint, which was sort of a composite of the ischemic and bleeding endpoint, in blue is the de-escalated group, and in red here is the control group, was actually better. It met criteria for both non-inferiority as well as superiority. Ischemic endpoints, as one would expect, were similar, but bleeding was significantly better with this strategy. And so, you could say that as much as guided de-escalation is helpful, in this population or in this study, even unguided de-escalation was equally successful. Now, I will sort of provide a word of caution. Very early de-escalation or discontinuation of aspirin is not a good idea. So this was from the Neo Mindset study. This was 3,400 patients from Brazil, and nearly 2/3 of these were patients who had come in with a STEMI, and 20% had high bleeding risk. And so in this patient population, low-dose aspirin was stopped at 2 days. And the majority of them were actually on high potent or a potent P2Y12 inhibitor, so prasugrel or ticagrelor. And on top here, you're seeing sort of the ischemic endpoint, which was worse with the monotherapy compared with the dual antiplatelet therapy. And the majority of the risk was actually up front. And then bleeding was significantly lower with the strategy, but it's a tough balance or a tough trade-off, because you're trading a higher risk of MI or stent thrombosis with a sort of lower risk of bleeding. And for most patients, that trade-off may be hard to swallow, but it depends on the patient, of course. Now, when you looked at definite or probable stent thrombosis, that risk was still under 1%, but it was 0.7% versus 0.2%. So a hazard ratio of nearly 3. And the majority of these events occurred within the first 30 days. So this again also suggests that the first month after a stent for ACS is probably your most critical phase. That's when you definitely want to stay on dual antiplatelet therapy. You want to stay on a potent P2Y12 inhibitor. And then if you're considering the tapering, which is like what I showed you for Talos AMI, then at a month, that's when you would potentially consider pursuing that. So what about that beyond 12 months? And that's certainly something that has been discussed a lot and has been studied. So the two biggest studies on this were DAT and Pegasus TIMI54. So DAT was with clopidogrel, and then Pegasus was with two different doses of ticagrelor, 60 and 90 milligrams BID. And both of them showed actually a reduction in MACE events or ischemic events with longer duration of DAT, but the penalty was in the higher risk of bleeding. So again, there's a trade-off which has to be really individualized to that patient. So you could definitely keep high-risk patients, let's say they have left main PCI, on longer-term DAPT, but then they have to sort of understand, the trade-off that they would be at a high risk of bleeding. Now, interestingly, you might have seen this. This just came out last month. This is the DAPT MVD study from China, very big study, 8,250 patients. 24% of these, so 1/4 had STEMI, but 65% were enrolled with unstable angina. And 2/3 of these patients were on clopidogrel, and then 1/3 on ticagrelor. And the follow-up was again about 3 years. And what they showed is that there was no difference in the in bleeding endpoints, but they found that there was a significant improvement in ischemic endpoints. They found an 18% reduction with longer duration. So they basically just extended DAPT beyond 12 months up to a median of 3 years. And they saw that there was a reduction in MI. So somehow in this patient population, they were able to thread that needle in which they were able to extend the duration of DAPT. They were able to extend the duration of DAPT, but they were able to do that without increasing the risk of bleeding. And so again, whether this would be applicable to patients that you and I would see in clinic, would have to sort of really be individualized. Now, what about sort of antiplatelet therapy or single antiplatelet therapy in general, long term? So you've gotten through the acute phase, you're now sort of in the more chronic or maintenance phase for these patients. What, we've always just done aspirin, low dose aspirin long term. Are there data to suggest otherwise? So there's actually been a lot of interest in this field. And so this was the Panther Collaborative in 2023. This was looking at 7 or 8 studies that included, nearly 25,000 patients that had been sort of either stayed on long-term aspirin monotherapy or P2Y12 monotherapy, primarily with clopidogrel. And what was interesting is there was a reduction in ischemic in the ischemic endpoint of CV death, MI, or stroke. And although all bleeding was similar, GI bleeding was actually also lower with aspirin. So particularly, I guess you could consider that patients who have, more GI issues or have a high risk of GI bleeding, certainly, you could consider, clopidogrel preferentially in those patients. Now, I will caution you, some of these studies actually included 325 of aspirin. They did not use 81 of aspirin. So maybe some of the higher risk bleeding comes from that. But it's certainly something that, is being asked more and more. Aspirin has become more of a legacy drug. Is that really, can there be something different for that? Now, HOST exam is an older study, and they just actually reported out their 10-year outcomes. And again, this was sort of aspirin versus clopidogrel monotherapy long-term in patients with CAD. And so top is, the primary endpoint. And you can actually see that this was lower. In blue is clopidogrel and in red is aspirin. So there was an 18% reduction in favor of clopidogrel. There was no clear difference in death. So death was, that is the one at the bottom. And bleeding actually also appeared to be slightly better with clopidogrel. So again, these are emerging data. There's no true sort of randomized data that's looking at patients long-term and saying, you're going to start from aspirin, clopidogrel, contemporary medical therapy. That's also very important. But certainly some emerging data in support of clopidogrel long-term rather than just doing aspirin long-term. Now, so coming back to this vignette, the patient that we discussed, she has ACS. She undergoes PCI of the LAD. What is your recommendation regarding TAP? And so based on what we discussed, she could take aspirin plus a P2Y12 inhibitor for a year. That would certainly be appropriate. Or she could, that's a class 1 in the guidelines, or she could do aspirin plus ticagrelor or prasugrel for 1 to 3 months, and then just do monotherapy with either ticagrelor or prasugrel. That would also be a class 1 indication. Now, less sort of appropriate, but could be considered is you do, sort of the more potent agents for a month, and then you could de-escalate to either clopidogrel. We discussed this earlier, that it could be guided with the genotype, or it could be unguided. Just at a month, you decrease them from potent clopidogrel. And then if they are high bleeding risk, you would consider just tapering to a single agent after a month, although this is not necessarily the same or the same level of safety or efficacy as the other strategies discussed. Okay, now the other sort of common scenario that comes up is, about 15% of these patients with CAD will also end up having AFib or have another indication for oral anticoagulation. Now we know that patients who are on chronic oral anticoagulation therapy with CAD are 7 times more likely to receive antiplatelet therapy. And we know from all these historic studies done nearly 30, 40 years ago that the aspirin and clopidogrel is not as effective as oral anticoagulation for AFib. And also aspirin plus thienopyridine is better than warfarin for patients with stents. So these are older studies, but the paradigm is, if you have somebody that has non-valvular AF that needs an oral anticoagulant, this is typically sort of low shear stress thrombosis in the left atrium, so it's a different mechanism of clotting, versus PCI with antiplatelet therapy, which is a high shear stress situation and platelet mediated in the arteries. And so typically you need antiplatelet agent for that. So if you have both combinations, do you then need to be on triple therapy, based on this? And so, I shared this expert consensus document in 2020 on patients who, need sort of this combination of therapies and sort of what is the best way of going about this. And so if you look at there have been multiple studies on this, and I don't want to go into the details of all of them, but every single oral anticoagulant has been tested, from warfarin to apixaban to rivaroxaban, edoxaban, and dabigatran, they've all been tested. And what we see is that bleeding is lower, whether that's major bleeding, trial-defined primary bleeding, and intracranial hemorrhage. That's all going to be better with a DOAC plus a P2 white well inhibitor compared with triple therapy, and there's no difference in the ischemic endpoint. Now, if you did want to use triple therapy, what is the optimal duration? So I think the answer for that comes from Augustus. So Augustus, again, was comparing 4 different strategies, but basically was looking at triple therapy with aspirin, clopidogrel, plus apixaban, full dose apixaban, 5 milligrams BID. And the comparison group was basically the same thing with warfarin. And so if you look at the difference up to 30 days, aspirin, so triple therapy compared with dual antithrombotic therapy on the left was clearly worse. There was a higher risk of bleeding there, but there was a significant improvement in the risk of CV death, MI, stroke, or stent thrombosis. And once you get above a month, you only get the high bleeding risk, but you don't get any ischemic benefit. So in the first 30 days, if the patient is low bleeding risk, if you're not particularly concerned that they would have, some major bleeding complication, then it would be reasonable to consider triple therapy, although I think that would be reserved for very few patients. Now, the other question is, or probably the more common question is, you have patients that have chronically been on antiplatelet therapy, now they need an oral anticoagulant. And so this has also been recently studied. So this was the AFIRE study from Japan. And what was interesting is, so they basically took patients who had been a year out from a stent or an MI, and they needed both an oral anticoagulant and a single antiplatelet agent, typically aspirin. And they basically randomized them to stopping all antiplatelet therapy. So aspirin was stopped, and they only continued on an oral anticoagulant. In this case, it was rivaroxaban, versus continuing both of those agents together. And what was really interesting is there's a reduction in bleeding against 2 versus 1, understandable, but they also saw an improvement in ischemic endpoints. And if you thought many people thought this was a fluke, there was another study called OAC alone, which was underpowered, but also seemed to suggest sort of something similar. But then more recently, this was the aquatic study from France. And so this actually trial was stopped early because of harm in the dual antithrombotic therapy arm. So 872 patients, 72 years was the mean, and the majority of them were men, and they were randomized to continuing the oral anticoagulant along with low-dose aspirin, or just being on the oral anticoagulant and then stopping the aspirin. And the primary endpoint was ischemic, and that was in favor of the single drug therapy, or just using the oral anticoagulant. Death from all-cause mortality was also lower, and bleeding was also lower. So it's very interesting. You are lowering the potency of your antithrombotic regimen, you're reducing bleeding, which you would expect, but you're also seeing a benefit in ischemic endpoints. So we've seen this from two studies from Japan now, and then this the aquatic study from France. So this is also something that I think needs to be looked into sort of in the future more carefully and individualized. So in conclusion, for primary prevention, the selective use of aspirin can certainly be considered. For patients who are undergoing PCI for ACS, shorter durations of DAP followed by P2Y12 monotherapy with more sort of potent strategies or more potent agents is definitely acceptable. Emerging data for long-term therapy suggests that clopidogrel monotherapy may be superior, better, at least reasonable to aspirin long-term. For patients who need both oral anticoagulation and antiplatelet therapy, the combination of P2Y12 inhibitor plus a DOAC is associated with less bleeding than triple therapy. The efficacy is preserved, and definitely clopidogrel is the way to go. And in select patients, you can actually drop antiplatelet therapy completely after 12 months and just continue them on an oral anticoagulant. So I'll stop there. Thanks again for your attention and for inviting me, and I look forward to any questions you may have.
Thank you, Dr. Dharam, for covering the guidelines so well with the case examples each. I really like the way you present so that it is very easy for our doctors here to follow, and I really appreciate the way you presented and made it clear that I think in long term, I think clopidogrel is also gradually replacing aspirin, and aspirin has some bleeding side effects, and that's why we tend to move away from aspirin gradually, slowly. I think we have Dr. Vijay Trehan, sir, the senior cardiologist, and Dr. Ramchandra with us. Any questions, Ramchandra, for sir?
Dr. Dharam, very beautiful and comprehensive presentation. We have combinations of aspirin plus clopidogrel here since many, many years, and now the combination is called GOLD, where you have statin also, triple drug combinations. And a lot of, I think almost 70 to 80% of patients are on long-term GOLD therapy. So they continue to take dual antiplatelets. What's your take on it, especially because almost 50% of our MIs are less than 50 years. So these are basically young people who would probably benefit really from a decrease in ischemic events and have low bleeding risks. So do you think it's justified to give this sort of combination long term like we are doing it here?
Yeah, thank you. That's an excellent question, and I think you exactly sort of touched upon the most important point. Actually, there are two great points you made there. So one is what is the efficacy of a polypill approach, which is basically what this is, and the second is if your bleeding risk is low, what is the penalty you would pay for staying on dual antiplatelet therapy long term? So the polypill approach is very, very attractive. We actually have a big, NIH grant. We're studying that using aspirin, either clopidogrel, prasugrel, and a statin in patients who have had ACS, PCI. And I think, there's data from Dr. Yusuf and others, and Dr. Pace, I think. But there's a lot of data that suggests that a polypill approach may actually improve compliance, and provide sort of more stable levels of these agents. So it's a very promising aspect. The one thing that is unclear, the polypill approaches in the US that we've been involved with, they are actually just a pocket pill. So there are 3 compartments where these are put. It's a little different from where you have an integrated pill which has all of those agents in there. And I mentioned that is because what is unclear, at least on the FDA side here, is whether the pharmacokinetics of the individual drugs would be the same in a combination drug or a combination polypill as they would be with the individual drugs. So that, at least to me, is unclear, whether you can achieve the same aspect with these combination polypills. But, presumably that's been tested and that's worked out okay. Now, the other point about, sort of young MI patients, and I think you're exactly right. I think that was a difference between, Pegasus, DAPT, and the Chinese study I talked about, the DAPT MVD study, is that, if you're lower bleeding risk, which presumably most low or younger patients are going to be that, then I think now you have the evidence based on this study to really support long-term use of dual antiplatelet therapy. At least for now, the data extends out to 3 years. Now, whether you decide to use that even longer is, hasn't really been studied. It's really hard to study. But at least out to 3 years, if you have lower bleeding risk, you certainly consider that. So I think those are both excellent points.
Thank you, Dr. Dharam. Any questions on hall? Anybody? Okay. I think you made points very clear. I think less ambiguity and less questions, I think, here. But I really like the way you presented with case examples, how we day-to-day practice individuals. And the primary prevention example also, it's very valid in our country, because a lot of people also keep asking the same question as what you mentioned. So depending upon the risk, you decide whether you to give aspirin in those or not, and you made those points also very clear. Thank you again for your time, and thanks for staying for late for us, and I really appreciate your cooperation and participation. Thank you, Dharam. We'll proceed with the
Thank you, Dr. Srinivas. Thank you.
Thank you.
Bye. Thank you.
Okay. Will you introduce, sir?
So very